Last time we were looking at this diagram, and I'm just going to revisit it very quickly. So we were talking about the issues of, as we move further away from the heart, go the aorta into the smaller vessels, we see that diastolic and systolic, the difference between them starts to narrow, and the overall average pressure does decrease. We did talk about some of the resistance factors in the last video. We talked about the role of radius and how important it is, and laminar flow. But let's get more into why do we have this difference as we move in terms of systolic, diastolic range, and an overall decrease in pressure as we go from the aorta to the capillaries. One is it's simply a matter of fact of that we have a greater distance that the blood's traveling. And so there's basically more friction as we go through. The other thing, too, is we're going from large arteries to smaller arteries. So it's the smaller radius of the arterioles. They have an increase in the resistance, and that would slow it down and also try to bring systolic and diastolic would become much closer to each other. And then also, if we consider we're going from, yes, big arteries, but we're going to many, many, many small little arteries and blood vessels, and the total volume of these small vessels is quite large if you add them up. It's a summative effect. And that would basically mean same amount of liquid in a larger container, and we know that would decrease pressure. Now, as we go from capillaries, so we're down here, we're talking about this, when we go from capillaries to vena cava, the flow increases again. And that's because we're going from small to larger blood vessels, so the resistance will go down. Also, there's a large amount of blood that's forced in the smaller channels early on and as it moves through. But one point to remember is it never regains the velocity that we had in the larger arteries. Now, we should take a few minutes and talk about arterioles because they have the largest role in terms of control over peripheral resistance. And in past lectures, we've talked about that, is that their middle layer, their tunica media, has a lot of smooth muscle. They can do a fair bit of vasodilation. They're also on the proximal side. They're also on the proximal side of the capillary beds. And this puts them in the best position to regulate flow into the capillaries. The other thing about the arterioles is there's a huge number of them. They really outnumber any other type of artery. So they give you quite a number of spots where you could do this control. And as I said earlier, that they are more muscular in terms of their proportion and diameter when compared to the other blood vessels. And if we look at it, the arterioles produce about half the total resistance, peripheral resistance, and that's quite significant. And now we should talk about vasomotion, because we already said that change the radius of these vessels, we change the resistance quite a bit. And not surprisingly, for something so important, we would want to make sure that it's not just one control mechanism. And we have three categories. We have local control, we have neural control, and we have hormonal control. So all three of those together give you quite a bit of control over this peripheral resistance. So let's quickly look at local control. We're going to look at local control. And we're often talking about autoregulation. And what is autoregulation? Well, it's the ability of a tissue to basically look after its own metabolic needs. In this case, to regulate their own blood supply. And one of the thoughts is that if tissue doesn't have enough perfusion to it, you get a buildup of wastes, and the wastes will stimulate a vasodilation to increase perfusion, to take away the waste in that area. And of course, that would also be tied in with delivering oxygen and removing any metabolites, and we'd end up with basically the waste be taken away. There are a number of vasoactive chemicals secreted by a number of cells or formed elements like platelets. Platelets technically aren't cells, and in the blood chapter we'll see that they're part of the group that we call formed elements. So we have platelets, we have endothelial cells, we have some of the perivascular tissue that can stimulate vasomotion. Well, what type of chemicals can they release? Well, there's a number of them. We have histamines, we have histamines, bradykinins, and we have prostaglandins, and they really stimulate vasodilation. Then there's a number of other cells, or I should say, other chemicals that are released. Endothelial cells can secrete prostacyclines and nitric oxide, and they act as vasodilators, where endotheliums, they act as a vasoconstrictor. Another way of local control is a reactive hyperemia, hyperexasemia, blood flow. And this happens if temporarily blood flow is reduced or cut off to a part of the body. Then what happens is that you compensate by increasing flow above normal to it. And that's hyperemia. We also have angiogenesis. Angio for blood vessels, genesis for creation. And this is a growth of new blood vessels. This happens under certain conditions. It could be anything such as you cut your finger, you disrupt some of the small blood vessels, they will regrow, resprout. Also, this happens in the uterine line during the menstrual cycle. Also, any obstructions in the coronary arteries over time may lead to angiogenesis as you try and reroute new blood vessels around the obstruction. Exercise does it too, is that you'll end up with increased vascularization within muscles. And also this is important for many malignant tumors, that many tumors, I'm just going to draw, so that's tumor there, often what they do is they actually secrete chemicals. And what those chemicals do is they will stimulate blood vessels to send in branches to the tumor to basically supply the tumor. And that is certainly not a type of angiogenesis that's terribly beneficial. And there are some strategies in the world of oncology that try and address that. We also have neural control, and not surprisingly, we're looking at sympathetic control. Now, the vasomotor center is in the medulla, and this is going to sound quite familiar because we've already seen in the heart chapter that there's control centers in the brain stem. We saw the same thing in respiration, and it makes sense that I'm going to have vasomotion centers, I'm going to have cardiac centers, and I'm also going to have the respiratory centers all as neighbors because there's a lot of discussion that they have to do with each other. Now, in terms of sympathetic control, it stimulates, I'm going to underline it, most vessels to constrict. Okay, but the same signal can cause dilation of some vessels, and this happens in the skeletal and in the cardiac muscle. And that makes sense if you think about it, because where do I want to send the blood? I want to basically reroute all the blood I can to skeletal and cardiac muscles, so I basically take blood away from things like the GI tract, etc., and other tissues. The vasomotor center, not surprisingly, it gets input from and has automatic reflexes tied in with it. It gets input from baroreceptors, indirectly chemoreceptors. So I got baroreflexes, I got chemoreflexes, and I got some called the medullary ischemic reflex. Now, the baroreflex is a negative feedback response to changes in blood pressure. And basically what happens is an increase in BPs detected by the carotid sinuses. Sends a signal by, of course, one of the cranial nerves we know, glossopharyngeal, and it inhibits sympathetic, cardiac, and vasomotor neurons. And it reduces the sympathetic tone. It excites vagal fibers to slow the heart rate and reduce cardiac output. And the net result is we get a reduction in BP. And what if I have a decrease in blood pressure? Then I would be looking at the opposite effect. Now, baroreflexes are basically good for short-term regulation. They don't really have, they're really not designed for dealing with things like chronic hypertension. Basically, very quick changes in posture, getting up, sitting down, lying down, things like that is where they really have a big role. We're not going to spend much time here because we looked at chemoreceptors before. And of course, we already know that they look at especially pH, O2, CO2. And we've already looked at where they're located. And we've already discussed in class that their primary role is to adjust respiration. Now, they do have a secondary role in terms of vasomotion. And things like hypercapnia, hypercapnia, I should say, and acidosis stimulate the chemoreceptors acting through the vasomotor center. And what they do is they cause widespread vasoconstriction. So think about if I'm going to have a lot of the blood vessels constrict, the total container size for the blood is going to shrink, and therefore, not surprisingly, I'm getting an increase in BP. Now, why is the body trying to do this? Is by increasing BP, it would hopefully increase lung perfusion. So if I get more blood going to lungs, I'll hopefully get more gas exchange. And it also seems to stimulate breathing in addition.